Good morning, everyone. Good morning. Just confirming in the chat room. Why don't you let us know if you see us. Hello, everyone. Can you see us? Hi, we have a confirmation. Can you hear us?
Good.
Very good. Good morning, everyone. With that confirmation, I'm going to go ahead and I'll introduce myself first. My name is Chris Chaffin. I'm the Communications Director with the Alzheimer's Association New Mexico chapter. We are extraordinarily pleased to have with us today Dr. Stephanie McIver. She's with SHAC, which is Student Health and Counseling. She's the Counseling Director, and that's with the New Mexico Black Mental Health Coalition. And today's topic is the onset of caregiver depression among Black, Indigenous, and people of color. And I just want to let everyone know, as you have questions during the presentation, to go ahead and enter those into the chat. And then about 45 minutes or so, when Dr. McIver ends her presentation, we'll address some of those questions. Okay. So without further ado, it's my privilege to introduce Dr. Stephanie McIver.
Hi, thank you. Thanks for having me. And I am so pleased to be brought back into this dialogue about Alzheimer's and caregivers. I'm going to share with you a little bit about how I got into this line of work. It definitely differs from what I do during my work day at the University of New Mexico when I deal with much younger people. But at the start of my career, I worked in Alzheimer's. I am coming to you today actually from my role as the director of the New Mexico Black Mental Health Coalition. And we are a collection of licensed mental health providers across every type of licensure and every type of service who got together so that we can address the issues of a marginalized community here in New Mexico. And we also have a mission under the Bernalillo County Behavioral Health Initiative to provide outreach and education and consultation about issues that pertain to Black mental health clients, but communities of color in general. And our goal is cultural competence in these areas of mental health work. So I'm coming to you today primarily from that role. But I'm going to go ahead and share with you right now my presentation so that you can hear and see what it is I hope to convey to you in these next 45 minutes. And we're going to leave some time at the very end for your questions. So let's see, I think, there we go. Okay, so how I got into this work was that when I was in college, my grandmother, who was rather elderly when she started to have children, she was considered an elder mother. If she were alive today, she would be 121 years old. So when I was in college, she began to display some signs of dementia. And by the time I got to graduate school, she had developed what we know as vascular dementia. And my mother became a caregiver, and it was my first venture into understanding what it takes and what that course of that illness is. I was a pre-med major when I was in college, but it was my work in the emergency room in Atlanta, Georgia, where I realized, well, there are some significant healthcare disparities, and there are communities of color whose members continue to show up in emergency rooms over and over again with some of the similar issues. And that became more of an interest to me than the actual treatment of those issues themselves. I went on to graduate school at The Ohio State University, and my very first graduate assistantship was helping a professor there whose name is Dr. Janice Kikolt-Glaser. And she's actually foundational in the field of psychological research on Alzheimer's caregivers. And so my very first graduate assistantship was collecting data for Dr. Janice Kikolt-Glaser on caregivers. And I'll tell you a little bit more about her work then and why the work must continue, and must continue specifically around communities of color. Then I left Ohio State and I was in the Bay Area in California, and I began an affiliation with the Alzheimer's Association there, though informally, because I worked inpatient at Stanford Hospital. And we had a number of people who had many different types of dementias. And so that issue of what the course of that illness looks like and what family members experience and what resources must be available just was driven home more strongly to me then. And then after that, I decided it was time to return to New Mexico. I was actually raised here. This is my home. I live now just minutes away from where I grew up. And I decided it was time to come home. And my very first role when I came back to New Mexico was as a contract psychologist doing cognitive assessments of residents in long-term care facilities. And so again, drawing greater understanding about the course of that illness, about what caretaking is like, about the impacts on families, I really began to understand that even further. And then with my role, again, with the New Mexico Black Mental Health Coalition, I began to address more and more the disparities aspect in mental health care. And then now, beginning maybe 6 or 7 years ago, we began noticing some signs of dementia in my own father, who is a physician, who was a very highly practicing physician. And so seeing the course of the illness in his experience and my mother's experience has been really influential on my care. Please pardon my dogs in the background. We'll try to keep them quiet. But this was my early work with Dr. Janice Kikolt-Glaser, and she began publishing from this phenomenal pool of research on physiological changes. She was one of the first people looking at caregivers and doing not only psychological measures, but really physiological measures on how the body actually changes with the stress of caregiving. And what she noted was that there's a relationship, a clear relationship, physiological relationship and mood relationship between caregiving and these changes. And she noticed an earlier onset of depression and more severe depression, and also stress-related markers in the system that kind of triggered the onset of other illnesses in caregivers. And makes one vulnerable to other illnesses. So what she noted was that pre-caregiving episodes of depression, if you already were prone to depression or had any episodes of depression prior to your loved one's onset of dementia, then that puts you at greater risk for depression throughout the course of that dementia patient's care. But the problems with those studies is that they were really small. I did countless studies. We used a measure called the SCID, Structural Clinical Interview for the DSM, and we looked at all kinds of psychological illnesses that may be present in caregivers as a result of the stress of their caregiving. But those groups were really small as far as data is concerned and research is concerned. And they were primarily all white. And so while it was important data, really meaningful data, it was very clear that the research needed to expand. And again, the focus in the early years was on physiological factors, stress, and risk for mood disorder. So as many of you may know, being in the struggle at this time, that there are many, many different types of dementia. And so while Alzheimer's is one, and Alzheimer's is the one that we think most strongly about, it is important when we talk about communities of color that we talk about many different types of dementia that show up and look like, especially to family members and lay people in the community, look like Alzheimer's, but they're not Alzheimer's. They're other types of dementias. But the entire list is really important because the 4 that I have highlighted here, vascular dementias, are the ones that most commonly impact communities of color, most impact Black people, most impact Native Americans, because they're associated with all kinds of vascular conditions that we as groups are more prone to. So my grandmother, for example, suffered with a vascular dementia, which ended up in the later years of her life. When she was in hospice, as vascular dementia with delusions. And that is recognizable to people because that delusion aspect can make working with that dementia patient very difficult. They have ideas about themselves and others in the world that are highly distorted. And so I can recall the time when she began accusing my mother. There was a very paranoid delusion, accusing my mother of mishandling her finances, which is a very real and important concern among all elderly patients. But there is a delusional aspect for many dementias, and that was very powerful in my grandmother. So then as research progressed into the 90s and then into the 2000s, there were some things that began to be shown when those research pools broadened. And when we realized that, well, Alzheimer's actually affects communities of color at a higher rate than it does in white communities. And so it really behooves us to pursue that in research. And what we noticed was that people of color don't identify early symptoms as signs of Alzheimer's disease or related dementias. That's what ADRD is, as many of you may know. But people of color don't tend to recognize it as early as it is recognized in other communities. And, you know, there's a kind of caricature of the developing dementia in people of color, and even on some comedies that we know, there's humor that is attempted around it, and there's a lot of tolerance for the type of change in thinking and the change in behavior that may show up, particularly in the Black community. And it's not until many years later that that families and caregivers identify that that's what that is, or even taking them into an evaluation to determine that that's what it is. So people of color delay treatment. And some other things that we found is that African-American caregivers are found to be far more resilient in those responses to those negative effects of caregiving. So again, there is a more communal expectation, extended family, and again, a greater sense of tolerance for some of those changes that may be seen in later years. And in the Native American community, there certainly is a value around caretaking of elders and of managing the powerful symptoms that may develop of dementia, but not having a negative attitude about it, simply that it is one of the responsibilities of family life and of caretaking. Black caregivers who were studied in the early 2000s reported that there were actually some benefits and some gains and some satisfaction with caretaking their loved ones who were struggling with dementia, which was highly surprising, very unusual. But as I thought about it further and read more into that data, again, comes from this idea that there is an honor and a responsibility to caretaking elders. And there is also a terrific study on the spirituality of caregivers and how very strong spiritual foundations result in viewing that role as not just an honor, but very important for one's very salvation. A role that is given by God. And so it was found in studies of Black caregivers that they did not see depression set on certainly as early or as powerful, but actually some positive factors. And again, communal identity and caregiving as normative, not just in Black subjects, but was found in Native American subjects as well. There are studies of bereavement, and where we do see it set in is during the time if a family member is in hospice or after a family member dies, that there is a powerful grief process, but that people of color are less likely to endorse a sense of relief, but more grief, loss of a loved one. There is a more powerful economic impact of caregiving in people of color, especially Black caregivers and Native American caregivers who are already starting out under-resourced. And so the impact of that is what really contributes to the mood shifts when caregiving, and not the actual caregiving itself. And then the one thing that we noted most strongly is that people of color don't engage in advanced care planning. And so some of the difficulties and the inconveniences in finances and property and all of those decision-making can create a much higher stress burden for caregivers of color. There are some very specific pieces of research, much of which has come out of the Alzheimer's Foundation, and I love the work that the Alzheimer's Foundation has done on this subject with a particular roadmap manual, which is beautiful. And what they found is that initially, the life expectancy for Native American people was much less, 5.5 years less on average than all other groups. And so the onset or the development of dementia in those communities was not seen as much as it was in other communities, because people did not live as long, have as high a life expectancy in Native American populations. But that is changing, and that is a good thing that the life expectancy is rising. So, but with that, we expect to see greater onset of dementia and the issues that come with having to caregive. There are some variables that impact the onset of dementia and also impact the ability of caregivers and the coping of caregivers, and that's educational level, and which has a lot to do with being resourced to cope with it, but then trauma. And higher trauma earlier in one's life increases the risk for developing later life dementia. But for caregivers, earlier trauma can also make one more vulnerable to mood and anxiety conditions that are compounded when caregiving. And then what some of the research indicated was that some tribes across America, and there's 580 approximately tribes across America, and so they're very different, but there was a commonality that many tribes have absolutely no term or concept even for dementia. So the issue was not even really identified as a unique and specific one, but just kind of a normal development in aging. And there was a cultural value that was noted. Why diagnose it or seek any care if there's no cure? We'll just handle it ourselves. What we find now is that 1 in 5 Native American people who are 45 plus will experience a cognitive decline. And it may be the stress and the trauma that puts the Native American community more at risk for developing dementias. And 1 in 3 now, or I think as of 2014, 1 in 3 American Indian or Alaska Natives are caregivers. And so that's pretty significant. What we note is that there's community caregiving, and any very communal group is more likely to engage in communal caregiving and distribute the stress of the caregiving, and therefore mood, we see, is less strongly impacted. And again, the tradition of respect for elders. So let's talk about caregivers in general. So we do know that as of 2015 in the data, there were 7 caregivers to every 1 person who was at risk for dementia, which sounds good. So the distribution of responsibility and the caretaking, provided those 7 people are cooperative and engaged, which is a problem in many families. That was good in 2015, but projections about what dementia will become as we go forward as a nation, that picture changes. By 2030, we will have 4 caregivers to every 1 person at risk for dementia. So the distribution of responsibility for the care, and therefore the impact of caring, we anticipate will be much stronger. For people of color, especially African Americans and Native Americans, and Hispanic Americans or Latino Americans, and we'll see a slide coming up in a moment, caregiving results in greater work disruption, because being employed in environments that don't offer adequate benefits, don't offer leave time, don't offer sick leave, are not flexible, that tends to be experienced more in communities of color. And so the work disruption creates a stressor that can trigger the onset of mood disorders. There's a reduction then in income, a depletion of personal savings, which are not substantial. So if you all have looked at any of the economic data, the difference between white communities in America and communities of color and net worth is appalling. It is drastic and it is dire. And the last data that I saw is that even among Black Americans, the net worth a few years ago was $5. I had to look at that data multiple times to see if I had misread that, but it's $5. And since that a couple years ago, net worth has decreased and it's now in the negative. So when one is trying to caregive a family member and having no resources to do so, or little resources to do so, mood is more strongly impacted. And along with that goes food insecurity, forgoing personal medical care. And in communities of color, it's primarily for economic reasons or for reasons of sort of lack of habit of accessing regular care or preventative care, or distrust of health systems, which is more common in Native American communities than any other. One would forego medical care. But I do know that among caregivers in general, neglecting one's own needs because your loved one has needs is a real thing, is a big thing. What we are also seeing is that some of those physiological markers that Dr. Kiko Glaser was beginning to discover back in the 1980s are powerfully true in communities of color. There is an earlier onset of physical health problems that are related to those physiological changes that come with the stress of caregiving. And that there are higher rates of depression and stress, not so much because of the caregiving, but because people of color are already predisposed to higher levels of depression and more stress-related conditions. And so if you are already struggling with a chronic stress or mood condition, then the impact of caregiving can exacerbate that. And then there is a higher risk of mortality among caregivers who are people of color, again, because of the compounding of the physiological and the mood factors. So better data, we do have better data, and all of that I just reported to you came from those data studies that began in the early 2000s and went on to this 2016 National Plan to Address Alzheimer's Disease, which is a beautiful document. And then the Healthy Brain Initiative, which is the one that produced the roadmap that a lot of the information and the research around Native Americans dealing with dementia and their caregivers came from. But also what changed in the 2000s is that the Centers for Medicare and Medicaid Services, which you'll see online under the acronym CMS, and a lot of our provider data when we do billing is constantly referencing CMS. Well, CMS is a brilliant, enormous font of data and was critical in us understanding who the individuals are that are being impacted by Alzheimer's and what that impact actually is. And so what we found is, again, the increase in the numbers of dementia disorders in people of color, Black people in particular, Native Americans certainly, is escalating. And of course, the CDC has offered some terrific data to look at. So here's what we found with those combined pools of data and the projection data is that when we look at the prevalence of Alzheimer's disease and related disorders as a percentage of the population, we see that certainly the onset increases over the age range. So with 65, people who are 65 to 74, it is higher, certainly in Black Americans here. The next greatest race is with Latino Americans or Hispanic Americans. Whoops, let me go back. I didn't mean to advance that. But when we look at the age range of 75 to 84, which is where my father is right now, then we see that among Black Americans, the onset, the prevalence is highest. And then of course, once we get beyond 85 years of age, Black Americans are most strongly affected by Alzheimer's disease and related disorders, next Latino, next Indigenous people, and then our Asian Pacific Islander population and white population tend to be on par with one another across the board. And so these three groups, Black Americans, Hispanic Latino Americans, and Native Americans, are the populations that we have to seek support and resources for, and for their caretakers specifically. So across gender, what we also see is the same thing, fairly much the same thing, where Black, Latino, and in this case, white women are more strongly affected, more at risk for Alzheimer's. But in these two groups, well, in all groups, women more affected than men. So it's men who may in fact be caretakers. And it is that issue that results in some powerful mood changes over time when men have not been in a caretaking role before. So if they are not resourced or connected to services, we anticipate men of color who are caretaking women having a greater time, a harder time coping with that condition. And this references what I was talking about earlier, where there are delays in care seeking. And so on average, 6 years of delay in care seeking with Black dementia patients and their families, and 5 years delay in Indigenous communities. There is no data on this for Latino communities. That, again, we need to continue to seek. But the delay means that by the time education, support, and resources are given, if given, they're further along in that disease process with their loved one and having coped independently far longer. So that was significant. And so one of the most interesting and I think important pieces of research is this projection study. And it came out of CMS and the CDC, but really important. And so we have, what this is saying is we need to take this time to do this work as we are anticipating that those conditions will become even more dire. And so the new estimates of Americans with Alzheimer's disease and related dementias show that there are clear racial and ethnic disparities. And the communities that are going to be most affected, and in this study, African Americans and Hispanics, Native Americans don't show up enough, and these three groups don't show up enough in studies, nor Asian Americans and Pacific Islanders as much as they should. But if this is telling us anything, then we will also see the same sort of rate of growth in cases in the Native American community. So this is the data that really kind of shocked me, is that it's expected to nearly triple by 2060. So here are some conclusions that we've drawn about some of this research. Number one, clearly need more research for Hispanic, Latinx, Indigenous, and Asian caregivers. But the advanced care planning piece that I know is talked about in the Alzheimer's Association, that's significant for our communities of color, for our Black and Indigenous caregivers. And what that means is there needs to be more education in communities of color about that. But what that will require is the creation of what we refer to as trusted messengers. So if Indigenous and Black communities can identify who are trusted messengers that have this knowledge that they will hear that can guide them into advanced care planning. And that would make a great difference on the stress levels with caretakers. And the economic protections need to be given for those underemployed caregivers, and financial protection, because the loss of income, as I know was stated very clearly for New Mexico in the conference catalog, is important, because financial disparities are related to mood disorders. It is very hard to be poor and to have to care for families. And it is very hard to be poor and to have to address healthcare issues. And so we have some time, and hopefully with this next administration, we can begin to reinforce and protect and even grow some economic protections and protections in healthcare. We also need other resources. We need more providers who specialize in geriatric services in Black communities, in Native communities, and it helps if those specialists reflect who those people are. I'm sorry about that. And so that would be helpful if that could happen. So I am hoping that in our institutions, and being at the university, I am very supportive of any students of color who express interest in healthcare, either medical care or psychological care. And we need to create that pipeline who will help to serve our elders in the future. We also need to consider care sharing networks, because again, what we noted in communities of color, especially Black communities and Indigenous communities, is that when there is a communal sense of responsibility for our elders, there's a distribution of that responsibility, a distribution of the weight, and greater protections against depression and stress. And so if we could even formalize that in some way, that would be really terrific for the people who are caretaking individuals with Alzheimer's or related dementias. And then we need to train primary care providers how to assess and diagnose these disorders in people of color, because that delay in care seeking for dementias isn't purely because they have not gone to the doctor. They've gone to the doctor, but their physicians have not noted that some of the things that were being reported may in fact be signs of dementia. And so the sooner caregivers' experiences can be validated by primary care providers who are trained to notice it and catch it and diagnose it, the better. And the sooner caregivers of color can receive support. And then we just need to continue to address general health disparities that are related to onset. The reason why we see more dementias in communities of color is because of all the general health issues that are present across America for communities of color that include issues of having greater trauma, food deserts, poor healthcare, lack of access, lack of health coverage. If we can address those things, then we can affect that risk for Alzheimer's disease and related disorders, and we can decrease the impact on caregivers. And so I wanted to call your attention just to a couple of resources that I used, and I thank you for giving me this opportunity, because it permitted me to go back in time to look at some of the research that I did long ago. And so there are a number of terrific studies that are there. In 2010, at this conference, Alzheimer's Association, the international conference, there was this terrific presentation paper on older African Americans and Latinos with cognitive impairment, that they actually live longer and are less likely to be in nursing homes, which means caregivers are going to be caregiving much longer and at home and without some of the supportive services. And then one that I wanted to call your attention to is the resource from Winchester. And right now I can't recall her first name. In 2018, there was a fantastic paper, and this is a physician who wrote on dementia in Indian country. And it's a terrific paper where she also challenged her people to begin to address the symptoms that we see or that they see in their family members earlier. But she was also calling for some of the same things that I was talking about. The Redenbaugh and Kiecolt-Glaser study in 1995 was on depression in caregivers. And again, while it addressed terrifically how the stress of caregiving can create depression, there wasn't a large enough sample of Black or Indigenous or Latino caregivers to draw a lot of conclusions from that. But what they did find is that there is a relationship between caregiving and depression. But again, for communities of color, we found that it's about being under-resourced and undereducated about what's available and what the process is that they are experiencing. Let's see, I think what I will do is kind of end there and open it up then, Chris, for some Q&A.
Thank you, Dr. McIver. And first of all, I just want to thank you for not only an incredibly important and informative presentation that had a lot of information that we really need to address more, but also for sharing your personal family experience as well. I think that's a very, very noble thing to do. So thank you. We've gotten lots.
Thank you so much.
Oh, absolutely. And lots of internal traffic too. Everyone was very interested in what you had to say. We are bringing up lots of things that aren't necessarily questions, but sort of comments on some of the things that you have. I'm going to go over them all, but one pressing concern that we have is everyone was so pleased with your materials that they're requesting two things: your contact information, and if you're willing to share your PowerPoint.
Most definitely. And in fact, I was telling Chris before we begin, I would love to share my PowerPoint. So, okay, you know, please feel free to send out the one that I gave you. The one that I gave to the association has the information about the New Mexico Black Mental Health Coalition and our Behavioral Health Initiative grant on there. And I'm very happy to share that.
So what I'm going to do then, sorry, I didn't want to make too many promises. I'm going to share my email address, and I have yours, Dr. McIver, and I know that you've updated your PowerPoint. So I'm going to just have you email me, and I will get it to the people who are interested. And for the people who are on our meeting now that are interested, please just email me. I just posted in the chat my contact information. And then as far as yours, are you comfortable, Dr. McIver, with me sharing your email?
Well, I put in the chat the New Mexico Black Mental Health at gmail.com.
Oh,
and yeah, and I would love for people to reach me there.
New Mexico, and Dr. McIver, for the benefit of the audience, cannot see the chat. So it's New Mexico
Black Mental Health. It's NM Black Mental Health spelled out at gmail.com. NM Black Mental Health at gmail.com.
So I'm about to post that, and everyone who has more specific questions that we might not have time to fully address, you're welcome to use that, as well as concerns from the content that was presented. So thank you for sharing that.
You're welcome.
We had a lot of requests for that. We had some comments. Let me just run through. I'm reading as we go. I'm going to kind of go backwards. Could you recommend some resources for primary care physicians addressing cultural competency in recognizing cognitive changes in patients? Thank you.
Oh, wow.
Pretty heavy one.
Yeah, that's a pretty heavy one. And I will actually have to go into my stores to find it. There are lots of things on cultural competence, and we even provide that. Under the New Mexico Black Mental Health Coalition falls under an umbrella organization called the Black Leadership Council. And there is a health organization comprised of medical personnel and nursing personnel who are doing cultural competency work. So if you will please message me at NM Black Mental Health, I will hand off that request to the medical health organization to address. And again, our roles have been in addressing cultural competency. And I think that's a very important thing to do. And yes, I will send you information on that.
Okay, great. And then just FYI, this platform is allowing 2 ways to view. And so sometimes people are only seeing the chat from Zoom, sometimes from the platform. So forgive me if my eyes start to go this way.
Okay, that's all right.
We had a couple of concerns that are probably directed toward the association regarding prevention, in quotes, and the search for a cure. And I posted a link, folks, in there that has some of the information about modifiable risk factors. And I'm not going to take up Dr. McIver's time with this, but right now there is no prevention for Alzheimer's. There is hope in the forms of various researches like at UNM. Dr. Bashkar is working on a vaccine that's not on the market yet. There are no real preventions on the market yet. Hopefully there will be at some point. There are things you can do with your own health. They're called modifiable health factors that will stay off cognitive decline. They don't necessarily prevent Alzheimer's disease. And once we know what prevents Alzheimer's disease, we're going to let all of you know that too.
Absolutely. Yeah, and I wanted to jump in there and say, you know, my family, I have a sister who's not in the health field, but she's very much one of those, you know, granola, a naturopathic health promoters. And she's on our case all the time about all the things that we do with our health that may put us at risk for a lot of things. And so for many years, she has been on this thing about aluminum. And we know that there are a lot of sort of rumored issues about the relationship between aluminum and Alzheimer's and all. And what I've just decided with her, so she wants us to rid our entire existence of aluminum to stave off any risk. And that is a preventative measure. But what I've decided is, you know what? If I can do anything that just increases my health across the board, I will do it. I don't know, and there's not a lot of research that there is a causal link, but I will do that. And getting exercise and doing brain practices and eating well and all of those things that I can do, I will do. So yeah. That
Yeah,
was the,
those are, yeah, it's what's often says is that's what's good for your heart is good for your brain.
is good for your
And
brain.
yeah,
Yeah,
so that's, but that's a whole nother breakout session at some
it
point. So
is.
take a look at the link. Hopefully that answers those questions and concerns. There was another question about um, respite. Now let me quickly see that one.
Respite care for caregivers.
During COVID-19.
Um,
Sylvia, if you can send me your email on that, I'll try to get some information together for you that. I believe that there are some, the Alzheimer's Association offers some forms of respite for family caregivers around the year, regardless of pandemic, but I think there are some other things going on. So Sylvia, please email me. You saw my email address there, and I'll get some respite information to you. Unless you'd like to address that, Dr. McIver, we can move on.
well, and that does bring up that I did not address most specifically, okay, what can caregivers do if mood and stress is an issue? And I often talk about rotating out. So whenever you're in a highly stressful situation, it is really critically important that you have an opportunity to rotate out of that role for a period of time. And that's where having that network of supporters is really important, and why that data about 7-to-1 versus 4-to-1 in our projections of potential caregivers is really important, is we need to be able to rotate out. And sometimes that requires some pretty strong conversations with family and other supports around the roles that they need to play. But probably more importantly, like the more stressed we are and the more depressed we get, the less organized we become in our thinking. And so when people ask us questions like, let me know, or actually they'll say something like, let me know what I can do to help, which is actually not a helpful statement, because it's difficult for people who are very stressed or depressed to come up, certainly in that moment, with what other people can do to help. So what I want you to do is, in your quiet and peaceful time, when you're less stressed, is to write a list of things that it would be ideal to have help for. Getting groceries, coming in and sitting with your loved one. We have a hard time coming up with those things in the moment. And that's what keeps people from actually receiving help, is that we cannot articulate what it is that we need. So that's one of the first things that I would recommend to all of you all, is make that list in your quiet, less stressed moments of all the things that you need. And that's what you tell them or hand them when they say things like, let me know what I can do. That's what you can do.
Very good, thank you. We had a comment about something that we hear a lot about, which is the sandwich generation, which
Yeah.
is folks who are taking care typically of an adult with dementia, their parent, as well as raising children. So the comment, which I think they wanted you to add some reflection on, is about resources and the fact that that situation adds more stress, leads to more circumstances that foster depression. And caregivers often have to choose between institutional care versus care at home because they don't have supports. Yet we know the benefits of keeping our loved ones at home. Did you want to reflect on that for a moment?
Absolutely. And I think that, again, is where the care networks come in. And I've been hearing more from people in my personal life who are in that situation that is particularly hard now because they're homeschooling. So not only are they parenting youngsters, now those youngsters are at home at the same time that they're trying to caretake. And one of my friends has actually taken to using her social media space as calls for help, which is the most efficient way to do it, actually. And I think that's terrific. And so I think thinking in terms of care networks, and use your social media space as your care network, your potential care network right now. And as simple as putting out a call to, I need someone to take my mother to the doctor, which was a call that she put out earlier last week. And 9 people showed up and did it. And what we're challenged by as caregivers is our willingness to let go, our willingness to give over responsibility to other people. So yes, make some discerning decisions about who you will trust to do that, but use your social media networks to put out calls for help.
I like that one.
Yeah, I think that that's worked really well with her. We respond, and things that we don't even think to ask for, which is, can someone bring us dinner? And you will be surprised how many people come forth and do that. We live in an amazing world, and despite some of the terrible examples in our media, most people care. And most people, if they're not in it, they can empathize with it. And most people who are not in it will be in it at some point. And so we're often surprised at people's willingness to step forth and do that. So put out the call, use your social media networks to do so. And again, going from that list that you've already taken an inventory from, of what are the things that I wish somebody would help me do? What are the things that I need? And people will come forth.
No, that's great. We talk in our classes a lot about putting together a care team made up of many people with very small responsibilities, and that makes life easier.
Absolutely.
We have another statement, but I think maybe what they wanted a little bit more from you is about the need for more bilingual, biliterate, bicultural healthcare providers and allied healthcare members. Did you want to speak on that?
Amen. Say, you are absolutely and totally and utterly and completely right. And, so whatever you all are doing in your own worlds to encourage young people and people who are in school to go into all of these pathways, and there are lots of care pathways, nursing pathways and social work pathways and mental health, psychology pathways and medical pathways. But we need everyone. And the reality I think will hold true is that people will find trusted messengers and trusted caretakers first among people who reflect who they are. And it is very important, especially with language. We're in a state where we have a number of people who do not speak English, their family members don't speak English, and we need to be able to care for them. So I am just all in favor of that. And I would love to see government, legislation, education catch up to actually fund people who are going in these pathways that we know that we need, and with skills that we know that we need. So I'm all in favor.
Very good. And another comment that sort of tags right along with that regarding language is a remark on how fascinating it is why so many cultures, peoples, and languages do not have the adequate language regarding dementias.
To describe this condition, exactly. And it wasn't until, I remember when I was in graduate school, even in the 80s, where Alzheimer's was kind of a new idea. It was a new concept back then. And it's not that we didn't see these symptoms. I mean, we can read back in, medieval literature around examples of elderly who behaved in such a way that now we can recognize as having dementia. But we didn't talk about it that way. We talked about it as just getting old, and normalized it and accepted it and accommodated it. So it is a pretty recent thing to identify these disorders, and it continues to be fascinating. Yeah, the Native American tradition across a number of tribes of not even having a word for it, that I found really powerful.
We have a lot of comments, quite a bit. And I was just going to say, not to lump all these together, but we want to spend our time as wisely as we can. A lot of things regarding resources, financial support, planning for full-time caregivers. I would throw in there legal planning. There's a lot of different types of things that I would just say, quite honestly, the Alzheimer's Association does have a lot of free programs that are geared toward those specific topics, and including respite. And so you may want to just check out our website, and I'll enter that now in both chats. But did you have anything, Dr. McIver, that you wanted to say just about resources in general and potentially financial?
Well, certainly financial and legal, I think I was thinking about. And I typically refer people when they're under-resourced, especially for legal planning, and that's a hard thing to do on one's own, is I will refer them to like the Southwest Women's Law Clinic that can help women with legal issues, or even the law clinic at the University of New Mexico, and just to inquire about, can there be some help with some of those issues when you need that. In terms of mental health resources and other financial resources, now we created this for UNM, but I'm going to give it to you anyway to go on and peruse these resources, and it's mentalhealth.unm.edu. And the first page is all the mental health resources that are available on campus and across campus. But if you click on the essential services page, it was created for the university, but I go on there, especially the financial services link, to see what's available across the state. And we have a case manager whose responsibility it is to keep apprised of all the financial services available. And so she keeps up to date. And go on and see if any of that can be helpful to you. And if so, print it out, take it, link on those links. I hope it could be of service to you all.
Very good. I'm also going to grab the post for the ADRC as well.
Okay.
We are still getting questions. One was regarding adult daycare. Our executive director, who is enjoying your session, is actually fielding some of that. One question is if you're still involved at UNM, which I believe the answer is yes, but did you want to elaborate about how your professional role at UNM works?
Well, I direct the counseling service, a staff of now 11 clinical providers and psychiatrists and psychiatric residents to provide mental health services for the student community at UNM. Now, the interesting thing about it is people think that colleges and universities are primarily traditionally aged students, 18 to 24, or young grad students. But the oldest client that we had in our mental health service was 95. And what we're finding, even in collegiate healthcare, is that we're having to expand our knowledge and our skills to accommodate older developmental ranges, because students are getting older. And UNM provides opportunities for non-traditional students, primarily older students and parents, retirees, to come back to school. And so we see them in our health service. And so I am having to now, kind of practice up again to do cognitive assessments and do all of that. And I think that's a great thing, that our university life spans the whole mental range. But that's the kind of work that I do on campus.
Very good, thank you. This one goes back to your overall topic, I believe. Is there a specific depression screening tool for caregivers?
Yes. Okay. So, and you can get this online. So go online and look for a screening tool called the PHQ-9. PHQ-9. And you can just do a search, a web search with that, it'll come up. And that is the most commonly used screen for depression. It's a very brief screen. And it's what we use and what we encourage primary care providers to use in their practice. And in student health and counseling, all of our medical providers, every time you come for a medical appointment, you will get a PHQ-9, and then they'll know if they may need to refer you to us. But that is available online for you to do and to take and to share with your healthcare provider. I found this measure. I was told to look for this measure called the PHQ-9, and I took it, and this is what it says. What can you do for me? And they, I hope, will play a role in helping you identify some care and getting you into care to address it. But we can treat depression, and the sooner we address it, the easier it is to resolve. So do look for that, PHQ-9.
Now, Dr. McIver, as I enter this, we have 2 chat rooms open. I'm not sure how that happened. But I Googled that quickly and I saw that several different sources were offering the PHQ-9. So I simply put Google PHQ-9, but did you want to recommend a specific trusted source for that?
No, they're all the same. They should all be the same measure. You may also come across what's called a PHQ-2, which is even briefer. It's a briefer version of the PHQ-9, but the PHQ-9, and it should be pretty standard and open sourced, and you should be able to access it. So anyone you come upon, look at that. That should be good.
Now, since we're running out of time, I just want to tell you that a lot of people were offering other resources in the chat room to each other. Thank you all. Explore those. Thank you, Dr. McIver, so much. This was an amazing presentation, and we look forward to working with you a lot.
Thank you. Thank you so much.
Thank you very much.
Yeah, and you all have a very happy Saturday.
Thank you so much. Thanks to all the participants. And if there are any other questions, just give me an email and I'll try to get with Dr. McIver and provide you what you need. Thank you.
Thank you. Bye-bye.